Hi, everyone, and thank you for joining us. My name is Julia Saracen, and I'm an injury prevention specialist with the Family and Child Health Division at the Vermont Department of Health, and I'm here with my colleagues from the University of Vermont Medical Center and Gardner College of Medicine, pediatricians Dr. Breena Holmes and Dr. Becca Bell. We're going to start our time today with a 30-minute Q&A session, followed by a structured content presentation. We've received some great pre-submitted questions on respiratory illness guidance and guidance for drug exposure in children that we will start our discussion with. Our structured content section will start at a little after 1:30 and focus on RSV and car seat safety. As we answer the pre-submitted questions, please feel free to ask live questions either by raising your hand or using the chat, and to share any follow-up questions or ideas. Did Becca join? If not, we can start.
I don't see Becca, but I was just with her at our 12 to 1 meeting. And so she is perhaps using the
There
restroom.
she is.
Oh, good.
She's joining us now.
I was going to make the joke about being the understudy.
Yeah,
The
thank you so
role of
much.
Becca Bell is being played by Breena.
Leo now she's with us.
I think she is. She probably doesn't know we're waiting for her, though. Becca, are you with us? Julia, do you want to flip-flop and talk about illness first and let Becca get situated? Okay.
So, Breena, my question for you, it was a general question on guidance for respiratory illness.
So, hi, everyone. Happy New Year. Oh, there's Beck. I wanted to start today, as we always do, by acknowledging that January is a rough patch for people in the great state of Vermont, but also for people who care for children and for parents of young children. So in the space of respiratory protocol, I love the ongoing efforts to figure this out together, and I want to acknowledge at the onset it's imperfect. What we know, and Becca has been very scientific about describing to us, is that if we hold children to no symptoms for their return to care, they will not be able to attend care for most of the winter. So what we find ourselves in is this gray zone of how do you navigate ill children and the pressures to for parents who need care for their kids. And so what we really want to remind you is that we all went through something very significant during COVID, where we got very tightly focused on when to send kids to doctors, when to get testing, when to allow kids back with all these protocols. And what we need to do now with our mental space is to get back to a place of understanding that there are general rules about illness. If you have a fever, you do not attend care. If you're too unwell to participate, if you're having difficulty with energy and not, able to participate in the care, you don't come back. But other than that, the persistent coughs, the respiratory symptoms without fever with kids that are doing well, we really encourage you to allow those kids back to the best of your ability. Now, we also have learned so deeply from you that this impacts your team, and that if there's something about a child's respiratory condition that you're worried and it infects your staff, and then your staff is out, you don't have the capacity to care for kids. So I'm not advocating or describing infectious kids returning, but when kids no longer have fever, their infection potential to others drops dramatically. So that's all like the language around just really wanting you to not feel like you need tight COVID protocols, and also in this world of common respiratory viruses, not everyone needs to go to the doctor to be cleared. Not everyone needs an official protocol. I think Deb is unmuted. There we go. But what really we want to discuss today and continues to come up with our efforts with you all is this relationship with the pediatricians and the nurse practitioners and family docs in your community, and the idea that you're at a little bit of a disconnect between what you're experiencing and what's coming from your pediatric and your child health professionals. So rather than just wish that your partnerships could be stronger and that you could figure out a way to talk through what it's like for you and also what it's like on the medical side. Today, we are suggesting that some of you dispatch and connect with the workforce in your community who can help you with this. And that workforce is called the Family and Child Health Coordinator in your district office for public health. And Julia's going to put the link in the chat, I hope, for me, that there is a public health nurse in all of your regions who wants to navigate this with you. And this is an actual offer. This is not sort of a, oh yeah, maybe. These people who are public health professionals, their job is to have relationships with the people who deliver healthcare for children in your community and to bridge that for you in these difficult spaces you find yourself where you can't you feel misunderstood, or you're getting kids back that are not well, or you're getting all sorts of communication from parents that pediatricians have said the kids are fine. And I can't think of any other way to broker this than to slow it down and let these FCH nurses help you. And what we'd really like is for those child health professionals to come to one of your meetings, if you do gather as a network, to just talk about what's everyone's experiencing. So Julia or Becca or Beth, what else? That was our primary answer. That's a long answer to a short question. But there's just very basic caring for our children protocols about when a child should return. And I know some of you go above and beyond that. And in that space, I would really encourage you to talk to your local teams to not risk that your protocols are really too stringent so that children are not returning to their important developmental care.
Shared some great additional resources in the chat. I'd just like to reiterate that the Family and Child Health Nurse Coordinators, part of their role is designated towards helping childcare providers. So that can look like however you need it to look like, whether it's supporting outreach, supporting with educational content and messages from the health department, and then just providing technical assistance. You can use those resources in the chat, or you can also reach out to me. I would be happy to broker any connections with your local health office and get you connected to those resources. They're very eager to work with you, and it's really something that you should all be taking advantage of.
Yeah, and I would love between now and March for at least someone to try, because we work in a quality improvement entity, this Vermont Child Health Improvement Program. So we have to try this out because it's set up so beautifully on a website, but until it's a real thing in your community, I need that engagement. I really need someone to try. So thank you. Now back to Becca.
Okay, Becca. The question we received is, do you have any resources or training for drug exposure in kids, such as the accidental ingestion of fentanyl or edible THC products such as gummies?
Yeah, great question. So I'll start first with opiate. So the question about fentanyl or other opiate exposures. So and I would love to open up a discussion on this too, but every childcare really should have Narcan in the building. And so we want to provide resources so that if you don't have that you can learn how to get Narcan. And we'll also provide some just training from the BDH, just some short videos to watch how to give Narcan. It's very simple. It's a nasal spray. And so everyone really should have that, whether it's for children, or whether it's for staff, whether it's for adult visitors or anybody who's in the building. You want to be able to provide that for them, and you would give it to them, and then you would call 911. So one thing we sometimes see is we see people being hesitant to use Narcan on a child. Like they're worried because they're not exactly sure what's going on, and they're worried about using it on a small child. So Narcan can be used on any age, any size, for really any reason. And so the signs of what we would say opiate intoxication would be not waking up, truly not waking up, like if you're kind of sort of sternal rubbing them and they're not waking up, and their breathing is irregular, that's something where you would want to consider, was there an opiate exposure at home before coming in, for instance? If that were the case, you would have someone call 911 and you would give Narcan. And depending on how long it takes EMS to get there, you may need to give a second dose, and all of that is sort of written out. When we have seen children who have been, say, in childcare and school, usually it's an opiate exposure that happened at home, and then they came in, and the symptoms start pretty quickly. And so the opiate exposure may be, I know the questioner was asking about fentanyl. I think it's a little less common to have a fentanyl or heroin exposure of a young child, but we see things like other types of opiate medications like Suboxone or like methadone. And so the child may mistakenly, and the parent might not notice, they ingest something at home, and then they go to school or they go to childcare, and they're pretty quickly extremely sleepy, becoming more sleepy, fall asleep, like can't wake up. So that would be the scenario. You would see those symptoms like right away, like basically right when they show up. So that's sort of the Narcan thing. And I would love to hear in the chat, or if people raise their hands if they have Narcan, if they've had to use it, or any questions you have about that. I did want to take a moment to just let folks know, as like a point of awareness, that we are seeing more cases of THC or cannabis exposure in your patient population, in this like toddler population, because of the bigger, wider availability of THC or cannabis containing gummies, like edibles. And so all it takes is like a little, one little gummy that can really make a child really kind of alter their status. And we've even had some kids who've been at the point where they've stopped breathing from it. So like a young kid who's taken a gummy at home. It's a tough thing because it looks like candy, and it's again something that can kind of go missing. And oftentimes parents are not as good at locking up those things as they are with other stuff. So in that case, again, if somebody like that is, if they're totally asleep, you can't wake them up, you would give them Narcan. It's not going to hurt, even if they haven't had any opiate exposure. We do not have a reversal agent for something like THC. So that would, again, be calling EMS. But that is something we are seeing, unfortunately, more. Generally, kids don't, totally stop breathing, but we actually have seen a case where that can happen. So just some awareness around that. There are, I was actually just gonna say, there are free lock boxes, and Julia already put that in the chat. So that would be something we could let families know about too, are the lock boxes that they can have in the home. And I'm happy to answer any questions about those too. But these ingestions are important. I'm glad someone asked about it, because we are sometimes seeing them happen in the morning and then they're dropped off at school or childcare.
And did folks just see the poll that just popped up? Because what we're really curious about is your access to Narcan. So we just did the poll, yes or no. And then I put in the chat the health department's website for overdose prevention, and it includes where to get Narcan for free in your community. There's a link for each community for picking it up at a different spot, as well as some pretty helpful videos of just how to recognize, but also how to administer Narcan for kids. And it's very clear on the Good Samaritan law that this is a protected activity for you, that you would never be in trouble for doing.
And folks see the screen I'm sharing?
We did, but now I'm seeing slideshow and resume
Yeah, it's kind of a
slideshow as
weird.
big. big fuzzy
Oh.
button.
That's
And I would
too
just,
bad. Let me try
While you-
again.
while you figure
what-
that out, Julia, I would encourage folks, we've got like 13 response to that quick poll around whether you have Narcan in your program. If there's anything you want to share about your experience, if you have Narcan or have used Narcan in your program, feel free to do so.
So I have a direct message in the chat from someone who's asking, do you let parents know that your staff, that your supply, that you have Narcan on your shelf? I love that question. That's sort of philosophic. I think it's essential everyone knows that there's Narcan everywhere. Because we're not just talking about whether you would ever have to use it with accidental ingestion with a child, but what about if one of your staff or a parent shows up impaired? I hope that answers it. And it does not hurt to give folks see the chat from Allie that Becca responded. If you have, it really doesn't do anything to you if you're not blocking the opiate response. So it's kind of magic that way. And we used to give, just to, really contextualize this. So, lots of different forms of anesthesia used on parents, pregnant people when they're delivering, and sometimes a pediatrician's they're not there during that. So you show up, there's a baby that isn't doing great, is having trouble, and we would routinely administer Narcan just in case it was a reaction or a side effect of something that had occurred in the delivery or the pregnancy. And somewhat dramatically, that if the child was experiencing an impact from opiates, they would wake up right away and be well. And if they
I'm listening to a
weren't, they
Q&A,
weren't.
so I don't have to talk.
I wasn't sure if that was a question.
I don't
I
believe
don't know that it was, but we did have a couple of people come off mute and it looks like they were waiting to speak. Grace, did I see you come off mute?
Yeah, I just wanted to share with Breena that our program, because Beth knows this, a few years ago, before Narcan was approved for pediatric use, we did have a need for it in our program. We ended up with the child going to the ER and having Narcan used there. And FYI, it is at the adult dose. It will do no harm in children.
Mm-hmm. That's terrific, Grace. Thanks for sharing that. I love the way Becca talks about this. I mean, this should just be, this is the most straightforward prevention thing in our world, right? So hopefully this access point of the website is up to date and works for you. Another thing, and what do people feel about telling? I mean, I didn't mean to be unilateral on that. All programs should share with parents that if you need it, I've got Narcan here, and is there anything philosophic there people want to talk about? It really helps to normalize that this is a disease that some adults experience. So showing up in all sorts of community spaces, wanting for that circumstance to not lead to death is a pretty powerful way to show care and concern.
I would only share, I don't think it would bother parents that we have it in our programs. And I don't share that we have it in our programs. But perhaps it would be a good idea to let parents know that it is available so that if there is a problem somewhere nearby in the program, they know that they can come to us as a resource. Like if it happens in the parking lot and they don't know that we have the Narcan, it might be helpful if they knew that we had it inside the building. But I'm not going to tell them to warn them, by the way, we have Narcan, it might be dangerous to you or your child. It's not going to be dangerous to them. It's not going to be dangerous to the child, and screw that. That's a dumb idea. But it could be helpful to you if you need it.
I do just
Grace?
want to take some time to go over those health department resources that are available to you all. As Breena shared in the chat, we have this great landing page for opiate overdose Prevention. And this has, if you scroll down on this is just a screen grab, but it has all of our great training information, such as the training videos that Breena and Becca mentioned. These videos are all short videos, very clear, explanatory, and all under 5 minutes. So it's a great way to familiarize yourself with how to administer, signs of an overdose, signs of what breathing and chest compressions look like. An overdose is a breathing emergency, so it's very important that people are breathing and to always call 911 first. You can also access on the same website any distributors in Vermont, but we also have this free mailed Narcan request form that's also accessible through the website, but I included a QR code just in case any wanted to grab that and go directly to that website. But these links will also be shared post-meeting. If you think someone's overdosing, as we shared, the first step is to call 911, administer naloxone if available, try to keep the child awake and breathing, lay the child on their side to prevent choking, and stay with them until emergency workers arrive. Also, if you do suspect any type of overdose, call 911. And if you do administer naloxone and it's not an opiate overdose, you will not be harming the child. We also have on the same website some great printable or electronic documents that you can all keep. We have this larger flyer version, but also a pocket version to keep on hand. And I was asked to explain the Good Samaritan law in Vermont, which protects individuals from civil or criminal liability from giving naloxone as long as you do not act recklessly with gross negligence or intentional misconduct. And as Becca shared, we do have these free lock boxes for cannabis, but these can be used for a variety of different substances. You should share this with people who attend your childcare, but you are also available to request this to put any products in your childcare, especially those home-based centers. Again, with the QR code, but this information will go out post-meeting. And here's the contact.
Can I share one other thing
Yes.
about this topic before we move on? There's sometimes these stories, that are really misinformation about exposure to like fentanyl in particular, and whether if touching fentanyl could create symptoms. And so I just want to reassure folks that those stories are not accurate. And so and I think it would be very unlikely that this would happen, but if you were, handling a child or handling their stuff and there was some substance that you were worried about that you touch, that's not something, despite sometimes there are news stories about people, like law enforcement generally is the story, and they touch fentanyl or think they do, and then they go to the ER. But that's, you can't get a fentanyl overdose from touching or sort of breathing around the fentanyl. So I just want to just bring that up too. And I think the reason why I say that is because that, again, creates a lot of stigma and makes people feel nervous about helping somebody out because they're worried about touching them. And that really shouldn't be the case. That's not a concern.
I was told by a DCF caseworker that, which obviously you're a medical professional, so I hope you know better than they do, but we were told that a child can absorb the fentanyl through the skin. So like even if the parent has it on them, or if the parent has ingested it, used it, and is then sweating, that it can be transferred from the parent to the child through the parent's sweat and skin absorption. Is this like way wrong?
Yeah, I wouldn't say that is true. I think it can be, things can be transferred through breast milk. As you may know, the scenarios that you've described, I will double check, but that's not something I've ever heard of. Sometimes we talk about absorbing through mucous membranes, which again, when we're saying that, we really mean like in the mouth, like absorbing through the gums, but absorbing through the skin, I've never heard of that, no.
Interesting, thank you.
Yeah.
Becca, we have another question in the chat that says, what about saliva kissing their child?
So I think, are you saying if, yeah, no, that's not something I'd worry about. So the concern is if there's an adult who had, you know, actual substance in their mouth and their saliva, and then, yeah, I wouldn't, that's not something I would worry about. I would just, these types of things, like we don't recommend, like we don't say parents need to like not be with their children. And if you think it through, like we prescribe opiate medications to people, right? Whether it's for pain or whether it's to help them with their substance use, and we want them to use them. And we don't recommend that people like stay separated from their child and they don't touch their child or hug their child or kiss their child. What can happen, even to like the most like just with it parents who are really doing their best, is they take their medication out, they put it on the counter, and they turn for 1 second, the child scoops it up and puts it in their mouth. Like that's what we see. So they're actually putting it in their mouths is really the issue. So, you know, I like to think about when we think about opiates, like there's all different kinds of opiates and people can get them for all sorts of different reasons. And there's really, from our standpoint, not a real difference between someone who's using it in a prescribed way and not a prescribed way in terms of like what we recommend for the child. We really don't want the child putting it in their mouths, but otherwise we don't tell parents not to be near or close to their child.
We have another question that asks, could a child get enough of a dose if they were to pick up or touch a fentanyl patch?
Yeah, I just provided we used to use
Yeah.
in the UC Davis has some really nice videos on fentanyl. So I shared those, and the direct quote is one case in which fentanyl can be absorbed through the skin is with the patch, but it takes hours of exposure to the patch.
That's right. Yep. Right. So when people have fentanyl patches, that's something that they have on usually for about a week or so. So it does slowly give release medication. So they would have to put it on their skin, and then it would take some time. If they put a fentanyl patch in their mouth and chewed on it, that might be like a different scenario, but just touching something or for a short time, I wouldn't worry about that, even a patch.
So, how would an infant, 9-month-old, have a significant amount of fentanyl exposure then if the only way that they're getting it is through ingesting like the pills left on the counter kind of deal? I have had experience with a child who had a hair follicle testing that showed that this child had exposure to fentanyl for more than 3 months consistently. Like, how else are they getting it if it's not through the skin, or like, is it just because they're mouthing toys that has it on it? Like, I just don't understand how do you expose an infant on a long-term basis if it's not absorbed?
Yeah, so I can't speak to that particular case, and I really don't know anything about hair follicle testing, but for sure, I mean, infants who are breastfeeding that's a scenario where they would be exposed consistently to opiates. So again, they have to really ingest it. It's not something that's just, if it's just around them or near them or touching them, they really have to ingest it.
Okay, thanks.
Hey everyone, we're a little bit at time to move into the the Becca talking about RSV, but I had intended in the conversation about illness in your programs to open it up to you all to use this opportunity to talk about specific scenarios you're encountering or some of the confusion that remains, or so I think Beth and Julie would allow a few minutes for that, but we're always available by email for specific scenarios. I think that's something Becca and I feel strongly about because so much of what you're experiencing is about confusion in this interface between your healthcare colleagues and your efforts to keep your programs healthy. So does anyone have anything that's swirling right now on January 9th in our great freezing state where respiratory viruses love to live.
Breena, I think one of the I'm not going to talk about COVID.
Thank you.
One of the You're welcome. One of the respiratory viruses that we have a lot in early Head Start is RSV. And when parents bring their children in shortly after diagnosis with RSV, and they're like, oh, no big deal, he's just got a little cough, recently diagnosed with RSV, and we find out from the doctor that, really kind of expected this child to stay home for a few days, is just a cough. Here we are in the classroom filled with early Head Start kids. Should we be a little more sensitive to the fact that this is a potentially could be dangerous virus for the other children in the classroom, or should we just say it's just a little cough? He doesn't have a fever.
That's a good bridge into what Becca's going to say, and
Yeah.
I don't have a great answer for you except to say that if you exclude kids with RSV, there'll be no one in the program, right? It's that common in the toddler age group. So the risk of RSV, which Becca will address and remind us over and over, it's the it's the sibling of the kid in your program that's at risk. So there's a lot of educational opportunities about that. And yes, I certainly.
These are infants. These are infants.
Oh, you've got the infants in the, yes.
These are infants, yes.
So I don't have a black and white answer for you. I do know exactly what you're describing, which is that you'd prefer them come back a little less soon. I think if the child doesn't have fever and they're acting well and feeding and smiling and not working to breathe, that it is okay. But I'd love to know what Becca thinks, because because especially in the infant world, it's not like the infants are all playing around a tower of blocks together, and but each case requires its own analysis for sure.
Yeah, I can add, and then maybe I'll just pull up my slides in a
Yeah,
sec
good
too,
idea.
Julia, if that's okay, since
Right.
we actually started talking about RSV. But yeah, I would say everyone gets RSV by the time they're 2 years of age. So they either get it their first RSV season or second. We tell parents if their child's in childcare or if they have a sibling, older sibling in childcare, like that infant is getting RSV that first RSV season. So there's that piece. There's also a piece where we actually don't recommend testing for RSV. And so what ends up happening is, you're so right, Grace, that RSV is worse than, in terms of causing hospitalizations in young children, than say like COVID or flu or some of the other viruses. At the same time, we don't recommend testing because it's, again, everyone gets it, and it doesn't change our management. We don't have specific treatment for it. And so then you are in a position where you might have families that got tested for whatever reason, but then everyone's getting RSV. So the other families are just not getting tested, which is fine. They don't need to get tested. And so that gets tricky too. So yeah, I would just go again, in terms of symptoms. Are they able to drink? Are they fever free? Are they breathing okay? And I would just go from that. So maybe I may have a couple slides that just about RSV, because we are in the thick of it. We are in the thick of RSV season. I know you're all feeling it because we're feeling it in the hospital. And so I talked about this in September, but I have a few more just slides and information about what we're seeing in the hospital that I thought I would show to you all. And it's pretty short. Okay, hopefully you see that, and I will make like the slideshow. So some of these slides look familiar to you, and I just re-put them back in just so that when we send these slides out to you all, you have them. But, and I already sort of mentioned this, so we get infected over and over again, which means you all and we all like oftentimes get RSV every year too, which is frustrating. It's the most common reason for children to be hospitalized in the US. That being said, because all children get this, it's a small percentage of kids that end up being hospitalized. So under the age of 1, about 2 to 3% of children are hospitalized, but because everyone's getting it, it ends up being something around 60 to 80,000 children under the age of 5 per year are hospitalized in the US. There's no specific treatment. Management is the same as other respiratory viruses. I think this is just helpful for you to know. I mean, we have a saying in medicine where we say all bleeding stops, and you know, in pediatrics, in the pediatric ICU, we say all RSV seasons end. And so, although it feels really rough when it's happening, the peak of it really lasts about 12 weeks, so about 3 months, and there's some tails. But what we see in Vermont is January is where it really starts to pick up. We really peak in February and March, and then we see it definitely in December and sometimes in November, and then also like sort of April, May. But I know this is a little bit small, but the green here is 2022-2023 season, which was a little bit earlier than usual, I think, just coming out of the pandemic. Red was last season, 2023 to 2024. And just to be clear, these numbers here are for hospitalization. So not just people testing positive, it's actual hospitalizations. And then this sort of purple is 2019 to 2020, so before the pandemic, which is usually where we are seasonally. We're a little bit moved forward up north here, where our peak is usually around here, like February or so. And I always highlight this because, again, this is your patient population, or your who you care for every day. And this is the hospitalization rates for all ages. So this blue here is over 65 years of age, which is the second age group that's most, hospitalized. But look, this is the 0 to 4. Like, this is like a problem that, like, we talk about so much in pediatrics, and people in other areas of medicine don't really get how big of a problem it is. Again, this is hospitalization rates. So huge for the young, especially those under 1. And then this is by virus. So this is all hospitalization rates for 0 to 4-year-olds. But the green is RSV, the red is COVID, and the blue is flu. So again, as to Grace's point, like, RSV is the thing that causes the most problems in this younger age group. I added this slide because it's just helpful to see the different seasons. So these, again, are RSV hospitalizations. This is 0 to 4 years of age. And so you can sort of see, again, there's a start, a peak, and a finish to every RSV season. I have to tell myself that, like, every year as I'm driving in at 2 a.m. to, admit another baby with RSV, it's like, it's going to end at some point. But this is a typical 2019-2020. We had a very weird season coming out of the pandemic where we actually didn't have a 2021 season at all because of COVID, and then sort of went into this other weird season. And then this, you all remember, this was when, like, places all over the country were setting up tents, and we didn't have to do this in Vermont, but all the beds were full, and it was very stressful season because all of these kids that didn't get it here were all getting it. And so we had, like, we're sort of crushed by RSV this year. This was last season, and then this light blue is heading into this season now. Those who are at high risk for hospitalization, the young ones younger than 6 months, if they've been in the NICU, they're born premature, even if they're like that 36-weeker, 37, they're only born 3 weeks early, 4 weeks early, they're still at higher risk than those who are at term. And then this is the one I always point out that people are surprised about, but the infants that get the sickest, who end up needing to be on ventilators, are oftentimes like a few weeks old, 2, 3, 4, 5, 6 weeks old. And they always have a sibling in childcare. So usually oftentimes the firstborn doesn't get really sick during RSV. They don't have a toddler sibling bringing things home. But I mean, I can tell you with the 2-week-olds, 3-week-olds that we're admitting, when I go in and I say, and do they have an older sibling? And they say, yeah. And I say, 2-year-old, I'm like, yes. And I say, are they in childcare? And they say, yes. Because that's what's going to happen, is that they bring RSV home to this, like, very new, brand new baby. If a child gets RSV for the first time when they're 10 months old versus 1 month old, they're just going to do better. So the more we can sort of delay that first infection helpful, but we have to protect them right from the beginning. And here's the good news. And I'm going to tell you a little bit about what we're seeing. So there's two options to protect infants. One is to give a vaccine to the pregnant person towards the end of their pregnancy so that they make their own antibodies. They pass the antibodies on to their fetus, and their fetus is born with those antibodies. Or the RSV antibody shot is so it's not even a vaccine, so you don't even have to let the infant like make its own antibodies. These are RSV antibodies, and you can give it right in the hospital right after they're born before they go home. So we've been doing that during RSV season, and or say you've got some babies that were born in August or September or whatever, they can see their pediatrician or their child's doctor and get this antibody shot. And this is amazing because nirsevimab, which is the antibody shot, really does reduce hospitalization. So it's not going to necessarily prevent the child from getting RSV. Like they might get exposed to it, get it, test positive for it, and just have more mild symptoms. It really reduces the thing that we care a lot about, which is hospitalizations and getting really sick. So the clinical trials showed an 80% reduction in hospitalization. In the real world, so far from last season, it was about a 70% reduction in hospitalization, which is amazing. Oh, sorry, I should have updated this, but we have maternal vaccine's been out, nirsevimab's been out. Like I said, we peak in February, March. So everybody should still be getting this if they haven't gotten it. We will see probably RSV until April or May. So every infant, if it's their first season, should be getting this. So anyone under the age of 8 months should get this. And then you just get it that one time. And then those who are at high risk can get it their second season as well. But that's a much smaller group. And I just want to let you know, just from the pediatrician's perspective, that families have been really open to getting this and really wanting it. And I think some of that has to do with our really bad season that we had 2 years ago. Like if they had kids then who got really sick, or they understood the crush that the hospitals were experiencing. So last year we had limited supply. In total, like throughout the whole season, we gave 2,000 doses of nirsevimab. This year, we're already at 2,700 total for the state, and we still obviously have many more months of the season to go. And I will say just, again, anecdotally, that people are pretty interested in getting this, which is great. We also have people getting the maternal vaccine. And an infant needs to be protected by one or the other. They don't need to get both. I think I said this last time and I got some followers. I don't really have a very active social media account, but I do have a TikTok account and an Instagram account. I don't post that often, but I think it is just about basically RSV and other stuff about respiratory viruses and mycoplasma, et cetera. And I do just want to share that I'll give you like the inside early scoop, but I don't want to be quoted on this because we're only halfway through the season, or not even about halfway through the RSV season. So far, we have had much fewer infants hospitalized with RSV. I have had 0 infant hospitalizations so far who have received nirsevimab. So again, it's early. I think I can reflect back in the spring a little bit or the summer with you all, but it feels really, really different this season so far. I don't want to get too ahead of myself, but if you've got families that are having babies, I think just letting them know, like, this is great news. If you have young ones that maybe were born before the RSV season started and so they didn't get it in the hospital, just letting people know about it would be great. This is like a huge deal. So we're really excited about it. That's all I have on RSV.
No one has any questions. I think this gives us some time to have our winter car seat safety discussion too.
Okay, great. I will talk about, so yeah, this is what I'm going to do. Look at me adjusting my slides on the fly. Okay. Let me share my car seat slides. I only have like 4 of them, don't worry. Okay, so you probably have heard about this. There's really good practice and good evidence to say that we want to, actually, not just for kids, but for adults too, we want to minimize the space between our harness or our seatbelt and our bodies. And that means not having a ton of layers there, like big bulky coats when we're in the car. And so I have put here 2 resources, and I have links here if you want to get them. There's this, this is from the VDH injury prevention and the car seat program, which is called Be Seat Smart. And so this is a card you can download if you want, or I think probably, I don't want to promise printed, we could get you printed materials, and I know printing is expensive, but you can download this, you know, for families if you're interested about the recommendation around winter coats. And I also put a link here to Healthy Children. We always talk about Healthy Children, which is this really nice website for parents and families from the American Academy of Pediatrics. I will pause and say that because like, I think this is good practice, it's helpful, but what I would say in working in the ICU and working in other injury prevention efforts, that this is sort of, in terms of thinking about keeping kids safe in cars, this is sort of, you know, on the spectrum of like things that we need to do or things that parents should do that have a big impact. This is probably less impactful and less important than what I'm going to talk about next, which is making sure kids are in the right seat for their size, really. And so, you know, car seats that are improperly installed, or car seats that are really not the appropriate, you know, size for the kid and not the appropriate position, is really much going to impact, you know, the child much more than whether or not they have a coat on. So I'm using this opportunity to talk a little bit about that. And one jumping off point is that the legislature passed an updated car seat law this past July. And so we've done some public awareness around this so folks know about it. And this is, again, from the Be Seat Smart website through VDH. I just want to let you know, and I'm going to move on in a second about this, but the way the law is written, it is written to include like the bare minimum of what folks should be doing. So the law was sort of updated to say, like, this is a minimum. A child under 2 years of age has to be rear facing, has to. That is the minimum, that is the floor. But what I would say to all you, and what we recommend as pediatricians, is you really stay rear facing until the child has outgrown that. And that is usually for most children around the age of 4. But the law says at least they have to be there at least 2. So the law, just so you know, is a minimum, and we've been using this opportunity to just sort of bring awareness and educate the public about child passenger safety. So the big ones for your population is really has to be rear facing under the age of 2, and then under the age of 5, they have to be in a harness. And again, bare minimum. This is like the law. It's not necessarily what we even recommend. So many kids can, you know, their size allows them, or the recommendation is for them to be in a harness up until like even up to 6, 7 years of age or so, 5, 6, 7, like that. So that's sort of relevant to your the families in your practice. But this is really the big thing, and this is also from the Be Seat Smart site, which is that we think about child passenger safety in there are 4 stages of child passenger safety, and that at each stage you want to stay in that stage until the child has outgrown that stage and then moves on to the other next stage. So the 4 stages are rear facing seat, then a front-facing seat with a harness, then a booster seat, and then a seatbelt. And so again, that rear facing seat required up to 2, but recommended. It's again based on the child's weight and height. It's probably going to be until they're 4 years old or so. Front facing with a harness, that might end up going from, say 4 or 5 until 7, 6, 7, something like that, and then a booster seat after that. So what we ask families to do is to check before you change. So before you move on to that next phase of the car seat, that you check to see if they really are ready to move on to that next phase. So we ask people not to rush it. This is just another, this is a national advocacy campaign that we worked on this past year. That was a check before you change awareness, just to say, each step forward in a car seat you lose a layer of protection. It's just the way it works. And so you want to keep them as protected as possible for as long as possible. And then again, just to let you know, on the VDH Seat Smart, you can also download these rack cards. This is, for instance, the stage 1. A lot of your families are going to be in the stage. Most of them will be. And then there's information on the website as well around how to get, if folks want to get their car seat fitted or checked. I know oftentimes what we see is that there's car seat fittings and installations that can happen when a newborn is born, like maybe at the hospital, they can get that done ahead of time. But we see things sort of drop off, say when they go to forward facing. There are still opportunities for families to go get that car seat checked, even when their child is out of the infant stage. And there's also opportunities for low-income families to receive car seats because they're very expensive. And so you can find all of that information on the website there. So I think the winter coat thing is a good reminder, but I think really if you're going to talk about car seat safety, especially in this age group, it's like, keep them rear facing as long as you can, keep them in a harness as long as you can. Like, those things are going to have a bigger impact. And I do think that oftentimes what happens is, and I totally get it, is you've got a family has their first kid, they're rear facing, and then their next kid comes and they're like, okay, we're gonna move this along. We're gonna have the infant take that seat, and we're gonna graduate the kid up to the next level, and they may just not really be ready based on their size and weight.
We do have one question in the chat I think we have time to answer, and I might pass this to our licensor on duty, Sarah Fitz-Pratt, but anyone can take it. Can you speak to the role of teachers as mandated reporters when children are leaving the center without proper restraint? If Sarah's available to answer.
Well, Becca and I can fill in if Sarah's. It's nice to see Stacy's name. Hi, Stacy. This is a really interesting question, more about sort of child neglect and intent, I think. So if it's sort of an inadvertent, folks don't have the information they need, or they don't have the equipment they need, versus the information has been shared and the system is inadequate in the car, right? Becca, I'm curious what you think. It feels very yes and to me. It is a form of neglect, but it's the child welfare involvement piece they might have a different reaction.
Yeah, I think and from when we think about it as pediatricians, I mean, I think sometimes we think about what does the family need and the resources, and sometimes it really, like, DCF needs to be the only way that DCF needs to be involved, and other times you can get families the resources that they need without involving DCF. And so I think I can't believe Breena didn't say this, but I would wonder, because Breena's favorite word, I would wonder if the family is even aware, the family may not be aware of what the recommendations are. I think one thing that helps is, we know this to be we see this in pediatrics. I know you see this, whereas, you have the recommendations, and some families, a lot of families are like, I just want to do like, what is the thing that's recommended? I want to do that. And some people are like, that seems like a little excessive. So that the recommendations is best practice. And then there's the law now. And I just showed you that the law has been updated. That floor has been raised a little bit. I still think that, again, it's fine for a law. But one way you can talk about it is just saying, like even if you say there's a new law, because you're not even saying that the family is knowingly, ignoring it. It's like, oh, just so you know, there's a new law, that here it is, because so that is something that it's a law, and it's new, and it's a way to educate about that. And then you're like, I'm not even saying anything. I'm just saying that's the law. That might be helpful just to start with the family. And then you could even say, it's recommended even that they stay rear facing later, but like it is the law. I just want you to know that they have to be rear facing until they're 2. I would start with some education, and I always try to say, like, especially with this new law coming out, it's a way to just make it sort of seem like you're bringing them up to speed with what's going on.
Hi, Sarah. I come off mute. Did you want to add anything in our last minute?
I'm so sorry. As soon as I tried to unmute myself, and then everything stopped working and I had to rejoin. Not sure.
Classic Zoom.
So I was just listening to what Becca was saying, which is exactly what we say, always start with the communication. But when it comes to making a mandated report, like, you are a mandated reporter. So if you see something that's not safe, I know once upon a time when I was working in childcare 15 years ago, I saw someone pick up their child and put them on the back of a motorcycle and just take off. So yes, I made a mandated report about that, so that someone could connect with them and talk to them about that, besides the childcare program. Yeah, it doesn't hurt to call.
I am going to tell you the truth, because I have done exactly this, and I know that Stacy is probably thinking to herself, we've already tried to do all kinds of parent education, because I know you did not let this slide, and you did your due diligence, and you've probably educated and educated and educated till you were tearing your hair out, because that's what I have done. And then I tried to call DCF, and they said, we do not accept this as a DCF report. Thank you very much for calling. You have to report it to the police. And so the police got involved. And then the parent put the child in a car seat. And it took us months to get him to do that. For months, he drove around with his child completely unrestrained in his car. So that's what you have to do, Stacy, but it works. You're welcome.
I do appreciate, I think, again, as a pediatric ICU doctor, and a parent, there's a ton of stuff to worry about. I will say, as a parent, one of the things I'm most worried about is child passenger safety. That's where we see a ton of morbidity and mortality, and like kids die. So I appreciate your attention to really, taking those steps and starting with the education, but really understanding this is like a very serious safety issue. So thank you.
So we are at time, but I'd like to give a very big thank you to everyone who came to the webinar today to attend and learn, and also those who submitted questions. In the meantime, before our March 13th webinar, please feel free to contact me with any health and safety questions or suggestions for future topics. We also have the registration link in the chat, but you should be expecting an email to go out closer to the date with the registration information again. And a very big thank you to Breena, Becca, Sarah for your expertise, and for Beth for your support and technical assistance. Thank you, everyone. Have a great rest of your day.